So the first line agents, they are on the basis of highest efficacy and comparatively lesser adverse effect. Second line are having efficacy, good efficacy, but maybe having somewhat higher adverse effects. And third line may be having comparatively less efficacy also and higher adverse effects also. So, and again the when we shift from first line to second line or third line, if we feel that the bacteria is not responding to first line drug, then we can add one by one. One thing very important we have seen in this case is we are not having any kind of single drug here. We have to always use a combination of drugs. So let us see one by one. First is isoniazid. It is a synthetic orally active antibacterial agent with bactericidal action against Mycobacterium tuberculosis. It is a prodrug which is activated through an oxidation reaction which is catalyzed by an endogenous enzyme CAT-G, which is exhibiting catalase peroxidase activity. It converts isoniazid into a reactive species which is capable of acylation of enzyme system, which is found exclusively in Mycobacterium tuberculosis. If you remember, therefore, we call that isoniazid is the most important drug for Mycobacterium tuberculosis or most important antibacterial drug, but it has no efficacy against other bacteria. And this is why Mycobacterium tuberculosis is very different than others, that the drug which are active against it may not be active against other type of bacteria, and the drug which are active against other type of bacteria, they are not active against this Mycobacterium tuberculosis. So it has got exclusive action of tuberculosis because that enzyme system is only present, and not even other Mycobacterium species. Very important is this. We have seen Mycobacterium avis complex, Mycobacterium lepri, but it is not there. INH is not that active in that cases also. So this is what chemical structure and how it is converted into it. The reaction of catalase peroxidase activate INH with the portion of enzyme INHA, which is involved in the biosynthesis of mycolic acid, and they are incorporated constituents of the mycobacterial cell wall. So it will thus reduce this mycolic acid synthesis. This enzyme is NADH dependent anyl reductase enzyme, and it is involved in the double bond reduction during fatty acid elongation. So this fatty acid elongation will not be possible, and thus this mycolic acid will not be properly formed, which will result into changes in the cell membrane activities. So this isoniazid is actually short name of this isonicotinic acid hydrazide. It is specifically inhibiting long chain fatty acid synthesis, which is activated in electrophilic species with acetylases in 4 position of NADH. So it is no longer capable of catalyzing the reduction of unsaturated fatty acid, which are essential for the mycolic acid. This is the structure. Then structure activity relationship, okay, this is the only one which is active in this class. Metabolism is extensively metabolized to inactive metabolites. The major metabolites are N-acetyl isoniazid. A very important thing is this is again, if you remember earlier sulfonamides, we have seen slow acetylator and fast acetylators. Here also it is similar situation. Okay, the enzyme which is responsible for acetylation, that is cytosolic N-acetyl transferase. Individual possessing high concentration of enzyme are referred as rapid acetylators, while those which are having low concentration are known as slow acetylators. And accordingly, we have to adjust the doses for fast acetylator because metabolism is faster. So you need to give more drug into this, and those which are slow acetylators, you have to reduce the doses. Acetyl hydrazine serve as a substrate for CYP 450, resulting into formation of reactive intermediate complex, which is capable of acetylating liver protein, and thus it causes liver necrosis. So INH is one of the very important drug which can cause liver damage, and these are various problems which are associated with this particularly isoniazid and hepatic drugs. they are hepatotoxic. The paracetamol is hepatotoxic, isoniazid is hepatotoxic, even rifampicin is hepatotoxic, and they can cause severe hepatotoxicity, which can be very dangerous. Means it can be even dangerous than tuberculosis itself, because once the liver is damaged, it cannot be saved. So continuous monitoring will be essential, those which are on isoniazid. And important thing is, it already it is known thing that person is having this hepatic insufficiency. So in that patients, this drug has to be given very carefully, or continuous monitoring is required in that case. So this is how. Then next is another is rifamycin antibiotic. Now rifamycin is a class of drug actually, just like we have got aminoglycoside or we have got macrolides. So similarly, this rifamycin is a class of drug in which various this rifamycin analogs are there. These are natural products that are produced by Streptomyces mediterranae. This chemical class is aliphatic chain, forming a bridge between two non-adjacent positions in the aromatic moiety. It has got semi-synthetic derivatives are prepared by conversion of the natural rifamycin to 3-formyl rifamycin, which is derivatized with various hydrogens to give product like rifampin and rifapentine. Rifampin and rifapentine have significant benefit over previously investigated rifamycin, where they were orally active. These two are orally active, highly effective against variety of gram-positive and gram-negative organism, and they have very high clinical efficacy in oral treatment of tuberculosis. So these are the chemical structures. Mechanism of actions: they inhibit the bacterial DNA dependent RNA polymerases, that is DDRP, by binding to the beta subunit of the enzyme that leads to blocking of the initiation of the chain formation in RNA synthesis. They are highly active against rapidly dividing intracellular and extracellular bacilli. This rifampin is active against DDRP and from both gram-positive and gram-negative bacteria, but it has got poor penetration of the cell wall of gram-negative organism. Rifampin, the drug has less value in infection in such organism. One more aspect I told you, that is why it is not used, although it may be active in some of the gram-negative or some of the gram-positive, but it is not used because if this microorganism forms resistance, which is not formed by tuberculosis, then it can be it can develop cross tolerance that can be passed to tuberculosis bacteria, and therefore it can be dangerous. Suppose there can be some other infection is there, and the tuberculosis is in mild format. So in that, this tuberculosis microorganism or these are not virulent in the patient. So in that cases, if the resistance is formed, then it can be very dangerous. Rifampicin and rifapentine are readily absorbed from the intestine. Food may interfere, and normally most of these are, you will find, particularly if you know about it, or rather you can search. We call it as in India, a very nice scheme was established by government of India, particularly health ministry, for that is tuberculosis control program. I'll suggest you to go for this India tuberculosis program. There is a separate website they have made for it, and they have got so many very active things they have done. Out of them, one important thing is there. It was found that there is a less compliance with the tuberculosis patients. Tuberculosis patient, they may forget, or if they take it along with food, then it will not be proper one. So they have made it typical observation therapy, that is called as a DOTS, that is DOTS, that is direct observation tuberculosis strategy is there, in which what happens is the patient whatsoever medications are received, then they have to make the chart like thing, or sometimes the person who is there, he goes to them and he checks whether the patient has taken it or not, because you know about it. We have seen that if the antibiotics are not taken, if the MIC, if the concentration of antibiotic goes less than MIC, then this bacteria will able to form the resistance. So the strategy is there, so that patient should not forget, because many times even educated people may not be knowing about this, that what it can cause. So this can be very difficult one, and therefore this is there, and in that they suggest patient that this should be taken early in the morning at empty stomach for some time. Do not eat anything, and then after 1 hour or 2 hour eat something or take any food, so that this absorption can be best. So normally early in the morning is recommended. Major metabolism is deacetylation, which occur at C25 acetate group to give D-acetyl rifampin or D-acetyl rifampicin, and they are still active antibacterial agents. Therapeutic applications, rifampin is always used in combination with one or more antitubercular agents. It is one of the most important there. That is, these two are always there, as I told you, INH and rifampicin. They are always there, and these are must in the treatment. The drug is also having potentially hepatotoxic and may produce gastrointestinal disturbances, rash and thrombocytopenia. So biggest problem with tuberculosis is one more problem is, already we have seen earlier problem that the bacteria is different. It has got dormant type. It goes into macrophages. It does not develop. It does not multiply rapidly. It takes times, even days, months to multiply. All we have seen. In addition to that, this is one more important, that most of time this tuberculosis and this bacteria is growing more in where the darkness, where sunlight is not proper one. So earlier days, if somebody knows, they can search it on Google search or something. In India, there were lot many some hospital-like things were made, and they were called as a TB sanatoriums. At many major places, these were there. These were government sanatoriums. It was so that there to achieve few things. One is just like we are making nowadays for COVID. Isolation units like that. These were isolation units slightly away from the normal locality, so that the person who is having tuberculosis will be away from the locality, will not able to spread, is one thing. Second thing, where abundant light is there, sunlight is there, because as I told you, it has been found that it is not working, it is not remaining active for long time in the sunlight area. Particularly now what is my concern in that is, what I mean to say is, this tuberculosis is found more in the slum and such areas. Why? Because again they have got not sufficient lighting there, they are very congested, the density is very high, and the what we can say, health and hygiene are poor, and because of that this tuberculosis are comparatively found more in the areas where it doesn't mean that it will not occur into middle class or high middle class or rich people, but definitely it has got more chances with the lesser socio-economic status. Now in that case, what will happen is, most of them again in these people, most of them are already alcoholic, they have liver problem, and if already liver problem is there, and both drug INH and rifampicin both are having hepatotoxicity, so it becomes very difficult to treat in these patients. We can see various things how it can be done. The doses can be changed, or other drugs can be added into it. It can cause this rash, thrombocytopenic purpura. It is also known to induce CYP3A4 and CYP2C isoform, and thus it can decrease the effectiveness. It is enzyme inducer, so it will cause more enzyme. And these drugs like oral contraceptive, corticosteroid, warfarin, quinidine, methadone, zidovudine, clarithromycin, and some antifungal agents, their metabolism will increase. Because of that, their concentration in body will decrease. So you have to adjust the doses accordingly. Therapeutic application of rifampicin is introduced in the treatment of pulmonary tuberculosis. Major advantage of rifampicin is that it is, when used in combination therapy, rifampicin can be orally administration twice a week during the intense phase of therapy. These are various phases of therapy which we shall be seeing. We call it as a regimens, followed by once a week during the continuous phase of therapy. Rifampicin is normally administered daily during the intense phase of the therapy, followed by twice a week dosing for the continuous therapy. This is because of the pharmacokinetic differences. Rifampicin can have the longer half-life than rifampicin. Then third agent in that is pyrazinamide. It is a derivative of nicotinamide. It is a bioisoster of nicotinamide, possesses bacterial action against Mycobacterium tuberculosis. It is an heterocyclic amide derivative. It is converted into pyrazinoic acid, which is an active, and this is taken up as a 5-hydroxypyrazinoic acid. It may be active totally or in part as a prodrug. This pyrazinic acid may lower the pH in the immediate surrounding of the Mycobacterium tuberculosis to an extent that the organism is unable to grow, and it has got structural similarity between pyrazinic acid and nicotinamide. It would suggest that pyrazinic acid may function as an antimetabolite for nicotinamide and interfere with the synthesis of NAD, which is important in mycolic acid function synthesis. Then metabolism, it is metabolized as I told you into pyrazinic acid, and then it is converted into 5-hydroxypyrazinic acid. The enzyme which is there, that is xanthine oxidase, because it is similar to that of nicotine or nicotinic acid, and this xanthine oxidase is metabolizing. There are in gout, if you know or if you remember, we are using xanthine oxidase inhibitor like allopurinol, etc. Then it can cause accumulation of this drug. This has to be taken care with. It is essential component of combination therapy for oral treatment. So this is third drug which is essential. So this means tuberculosis treatment, in that these three should be there. It is always there. So it is for oral treatment of tuberculosis. Then it is specially beneficial in that it is active against semi-dormant intracellular tuberculosis bacteria, because it is changing pH, which is toxic. That is very important. So in other cases, as we have seen, antibacterial will be active only when the bacteria is having active metabolic activity. But here, without that also, because of the ambience, it will change pH, and because of that, it will be beneficial. That are not affected by other drugs, and reduce treatment regimen to 6 months from the previously 9 months. So earlier it was 9-month therapy it was going. If we add pyrazinamide, it becomes 6 months. The major serious side effect of pyrazinamide is hepatotoxicity. So you can see that all the drugs which are there, which are most important, they are all hepatotoxic, and that is very, very important concern regarding the treatment of tuberculosis, particularly in hepatic failure. The next drug is ethambutol. It is actually ethylene diaminobutanol. So ethylene diaminobutanol is short form is ethambutol. It is administered as positive enantiomer, and it is 200 to 500 times more active as a bacteriostatic agent than its LEVO or minus isomer. Then mechanism, it inhibits the synthesis of this AG portion of the cell wall, that is aminoglycoside portion of the cell wall. It inhibits the transfer of mycolic acid into bacterial cell wall. It is also inhibit the enzymes like arabinosyl transferases, which catalyze the polymerization of D-arabinofuranos. It is a sugar which is leading to unique outer envelope, and that consists of arabinofuranos and galactose, that is AG type of this one. This ethambutol is block both synthesis of this arabinofuranos and galactose, and this LAM, that is L-arginine related moieties are there in the cell wall. The mechanism of action that accounts for the synergism that's shown between EMB and that is ethambutol and intracellular drugs like rifampicin. Damage to cell wall is created by ethambutol, improves the cell penetration of various drugs, and that results in increase in the biological activity. The metabolism is, it is orally administered, is excreted unchanged 73% with no more than 15% appearing in the urine as metabolite A or metabolite B, and they are inactive in nature. So this is only the drug which is not having any concern with the liver. Then next is streptomycin. It was we know about streptomycin, what kind of drug it is, and this is having very poor absorption from the GI tract, and therefore it is always administered intramuscularly. So this is what about streptomycin. Then next are second line agents. These are the second line agents which are working into when the first line is not used. So in first line we have seen so far 4: INH, then rifampicin or rifampin derivatives, then third is pyrazinamide, fourth is 5 we have seen, fourth is ethambutol, and fifth is streptomycin. So these 5 are the first line treatment. We shall see the regimens at that time. We shall see how the mix is. There are the agents, they are active antibacterial agents. They are usually less well tolerated or have higher incidences of adverse effects, or comparatively they have less activity. They are utilized in case of resistance, treatment of intolerance, or example hepatic toxicity, as we have seen it is there more, then we can go for any of these. So next of this is ethionamide. It is similar to INH. It is considered to be prodrug. It is converted via oxidation to catalase peroxidase, an active acetylation agent, ethionamide sulfoxide, which is causing inactivation of this INH-A enol reductase mechanism, and because of that it causes or it affects the synthesis of mycolic acid. The next drug is known as a para-aminosalicylic acid, or PAS, very commonly called as. It is a bacteriostatic agent. It is utilized as a second line agent. Combination of bacterial resistance and severe side effect have greatly reduced its value. It is very little use. It is acts as an antimetabolite. It interferes with the incorporation of para-aminobenzoic acid into folic acid synthesis. If you remember sulfonamide, same mechanism it has got. PAS, when co-administration with INH, it is found to reduce the acetylation of INH because it is a sulfonamide. We have seen all sulfonamides are acetylated. So PAS can also be acetylated and being a sulfonamide, and INH is also sulfonamide, also acetylated. They increases the plasma level of INH, and it may be valuable particularly for rapid acetylators. Metabolism is extensively metabolized by acetylation in the amino group and conjugation with the glucuronic acid and glycine at the carboxyl group. These are the two-step procedure. Next is cycloserine, that is seromycin. It is a natural product from Streptomyces orchidaceus, and it is the D-enantiomer is active. Cycloserine is readily absorbed after oral administration and widely distributed, including the CNS. This D-cycloserine binds to the neural N-methyl aspartate receptor, that is we call it as NMDA receptor, and it affects the synthesis and metabolism of 7-aminobutyric acid, leading to complex series of CNS effects. So it should be only used when this retreatment is necessary, on when the organism is resistant to other drug. It should not be used as a single drug, but must be used in combination with anti-tubercular drug. It is the active form of the drug, particularly with its action associated with the ability to inhibit two key enzymes, that is L-racemases and D-alanine ligase. These two enzymes it will be inhibiting. It is a rigid analog of D-alanine. Rigid means it will block it, it will make it a stable one, which is incorporated component of peptidoglycan portion of the mycobacterial cell wall, and therefore it is competitively inhibiting the binding of D-alanine to both of these receptor enzymes and incorporation into peptidoglycan. So thus it will affect the peptidoglycan formation. So this is how the actions is there. Alanine is converted by D-alanine racemases to D-alanine. That is, racemases means another isoform is there. Then with this D-alanine ligase, this D-alanine this is again important, actually you must understand this, that human body utilizes all the amino acid in levo format. Here bacteria requires in the dextro format, and it has got its own enzyme, that is it causes D-alanine racemases. So it takes alanine from human body, L-alanine, it converts into D-alanine, and then it uses D-alanine, it ligases, means it binds, it joins this all D-alanine moieties to make a peptidoglycan cell 1. So where this cell D-cycloserine will be acting, it will compete with this D-alanine ligase, and it will get incorporated instead of this D-alanine, and accordingly it will form the faulty or the structure which is not strong enough. Then next is capreomycin. It is a mixture of 4 cyclic polypeptides, of which capreomycin make up 90% of the mixture. So it is not a pure one. Capreomycin 1A, capreomycin 1B. So 1A is around 90%. It is produced by Streptomyces capreolus, and it's quite similar to antibiotic vaomycin. It is potent inhibitor of protein synthesis, that it depends on the mRNA 70S ribosome. It blocks the chain elongation by binding to either both of 50S and 30S ribosomal subunits. It is a polypeptide. The drug must be administered parenterally because it can be destroyed by enzymes in GIT. Kanamycin is another drug. We have seen it is aminoglycoside. It is a second line agent similar to streptomycin. It is only utilized to treat resistant organism, and then should be used in combination with other effective agents. The parenteral form of the drug is used, and it is aminoglycoside. It is poorly absorbed from the oral route. The effectiveness is narrow, and it has got severe toxicity. What are the toxicity of aminoglycoside compounds? Anybody? What are the adverse effect, major adverse effect of aminoglycosides? Major adverse effect of aminoglycosides.
Sir, nephrotoxicity, ototoxicity.
Very good. Nephrotoxicity, ototoxicity are the most common one. So, and it has got highest one, kanamycin has got. So, because of that, it is rarely used, only in conditions where it is a problem. Then next are fluoroquinolones. We have seen fluoroquinolones already. Mechanism of action, we know about it. Same mechanism of action: binding DNA guidance DNase complex, inhibiting bacterial DNA replication transcription, so that this drug exhibit bactericidal activity. Yes. This most active are the moxifloxacin. In that, although ciprofloxacin was also active, but the current one, the recent one, is the moxifloxacin, which is the most active against it. Then another is another mycobacterial infection is this Mycobacterium avis complex. It is also called as a atypical Mycobacterium disease. So for treatment of Mycobacterium avis complex, it is recommended that combination of drug is they are included, and there are at least 2 drugs are there. Example of this is clarithromycin or azithromycin plus ethambutol is used, and it has to be used for lifelong. The other drug which can be added to the combination, they are consist of rifabutin, fluoroquinolones and amikacin. It should be noted that INH and pyrazinamide are ineffective in treatment of this disseminated, which is spread throughout. Disseminated means Mycobacterium avis. So what the drug which are available, they are clarithromycin or azithromycin. These are what macrolides and ethambutol, or other can be rifabutin or fluoroquinolones or amikacin. No other antibacterial or anti-tubercular drug is active in this Mycobacterium avis complex. We have seen all these drugs earlier. We will not go for macrolide because we have seen their mechanism of action earlier. Then rifamycin, we know just now, we have seen them. Then next is leprosy, various drugs which are for leprosy. These are sulfone. They are actually analogs of sulfonamides. Instead of this amino group, the another cyclic ring is put into it, and that makes sulfone. They represent the major class of agents which are used for treating leprosy. The infectious disease, or it is because of Mycobacterial leprae. The initial discovery of sulfone came about as a result of studies for sulfonamide. So from sulfonamide they were found, and the first one and still most used is dapsone, that is 4,4-diamino diphenyl sulfone, diphenyl sulfone. So it is short form is dapsone. It is a bacteriostatic agent, same mechanism of action as sulfonamide, that is inhibition of this PABA or para-aminobenzoic acid incorporation and formation of folic acid. The metabolism of this is result from N-acetylation in the liver by N-acetyl transferase, and therefore this can have always interference with the drug which are getting acetylated. Then other drug is clofazimine. It is commonly used as a component of multi-drug therapy. It possesses direct antimicrobial and immunosuppressive properties. It increases the prostaglandin synthesis and generation of antimicrobial reactive oxidants from neutrophil, which have lethal effect on the organism. It is a tricyclic phenazine derivative, and it has got various metabolic pathways where it gets sulfate and glucuronide conjugate, and before that it gets dehalogenation and hydroxylations. Rifampicin we have seen. Thalidomide is you must be knowing, we have discussed during immunology, and also during toxicology we have discussed this, if you remember. So this is the thalidomide. The racemic thalidomide has been approved by FDA for treatment of erythema nodosum leprosum, and it is considered as a drug of choice. Mechanism where the thalidomide produces relief is thought to be associated with inflammatory cytokines, particularly it inhibits the synthesis and release of tumor necrosis factor alpha, TNF alpha, and it is very potent teratogenic agent. It is known to you. So these are how these drugs are effective. Thalidomide can only be used in males or the females which are not in the position to have children. In that cases it should be there. Dapsone has proved its to be single most effective agent and was used as a monotherapeutic agent. Despite the recognition that resistant strain are being there, combination consists of rifampicin plus dapsone plus clofazimine. It is used for treatment of multibacillary leprosy. Multi means more than one kind of strain is there. There are many strains are there. But if there is a paucibacillary, only one type of that, including tuberculoid and intermediate cases, only rifampicin and dapsone are used with doses as indicated above. Other combination which have been reported include rifampicin plus ufloxacin and minocycline plus ufloxacin plus minocycline, they can be used. So here we finished all these mycobacterial diseases and the treatment for that. One good assignment if you can go for is that, as I told you, you please visit this site. Very interesting it is. And that is this site, and even I can ask questions on that. We have seen various drugs, their pharmacology. Now next to that is you will find that there are various guidelines are issued. These are called as a RNTCP guideline, that is R means revise, N means national, T means tubercular control program, CP. So these are RNTCP guideline, that is revised national tubercular program control guideline. We have got website of it also. In that various guidelines are given. This can help you in your therapeutics also, and this will give idea in your pharmacology also, that what are the guidelines and how the drugs are there. We call them as a treatment regimens, and for different kind of patients the regimens are different. Few more new drugs are incorporated, that is, one is bedaquiline. I'll go for this in our next class. Few new are there, some are in the pipeline. This I'll go for next class, which are anti-tubercular. But even now this website will show you, this National Tuberculosis Program website will show you how this new drug is from 2016. This bedaquiline is added into it. There are many very specific things are there about it. So for children, what kind of doses you will be making, what kind of doses adjustment will be making in the hepatic failure. If it is drug resistance, then what you will be doing. Very important thing is there are various diagnostic measures for just like culture sensitivity we have seen earlier. So culture sensitivity is done for checking the resistance form or change in the MIC with the existing anti-tubercular drug. Then there is one advanced technique that is called as CBNAT. Okay, this CBNAT is used for verification of the effectiveness of rifampicin into that, and all these tests are done in most of the cases, and then accordingly the dosage regimen is finalized. We have got various categories of tuberculosis. Actually it starts with we call it as a presumptive tuberculosis. That is on the basis of initial symptom, they call it as a presumptive tuberculosis, that it is presumed, it is assumed, or it is expected that this is a tuberculosis condition. Then going for various tests, maybe chest x-rays, then sputum test, and blood antigen test, etc. Various tests are done, and on that basis of this test, then it is confirmed. Then it can be confirmed what kind of tuberculosis, whether it is pulmonary, extrapulmonary. If it is pulmonary, then what grade it is, whether it is just initiation of it, or it has become very pneumonic type of condition where it is too much infection in lung is there. So accordingly categorization is done. Simultaneously drugs are checked, or the sputum cultures are developed, and sensitivity is done, CBNAT is done, and according to it is checked whether it is responsive tuberculosis, that is drug responsive, or drug resistance. If resistant, then resistant to single drug or multiple drug. As I told you, these two are very common, they are always there. These two are INH and rifampicin, they are there. Then whatsoever others are there. So accordingly they are made. It has already been mentioned many times that there are two types of regimens are started. These are called as the initiation regimen, and then other is continuation regimen. So both regimen are there. Initially it can be for 3 months, and then it can be extended to 6 months or 9 months depending on the case. So all this information you will get in the guidelines. Please refer it. You put it on group, those who are not absent, that what has to be there, and whatsoever your assignment type of thing is there, you will put it on group, that whatsoever you have gone through, what are various additional things are there. Okay, so go through it. If you have any difficulty, you can ask. One more thing is there, I am getting question, or I can see this communication going on your WhatsApp group about syllabus of first semester, this sessional syllabus. Actually we have already discussed about it long back, and if we make whatsoever suggestion was there, if you make it in this way, that all chemotherapy in one, if you go for all cell and genetic in one and all remaining in one, then it is not balanced one. Again it's up to you to decide, I don't mind, but let me tell you, let me warn you about this. So if now syllabus is too less, then the depth of questions can be increased, and if by chance those who will not able to score in this sessional, then for them the next two sessional will be gradually increasing the syllabus. So they should be stressed because there are 3-1, but it is the decision shall be yours. If you can attempt it, it's good. For me, anyway, up to third sessional, I will be asking on 100%. That is, suppose here you put maybe 20%, in next you put 30%, then in next it will go around 50%, whatsoever it may be. So accordingly, or now if if you are going for 25, in next it will be 35, and then it will be 40%. So this will be like this. So if you are ready for that, I don't mind. Okay, from my side I am not compelling, but only thing is you have to think it wisely, you have to plan it wisely, and everybody should think about their own advantages and disadvantages, what positive, whether they will able to study that much exhaustively or not. Because as I told you, so many drugs, even so far in antibacterial drugs, so many drugs we have studied, so many penicillins, so many cephalosporins, so many ciprofloxacins or fluoroquinolones, and apart from that other drugs, again many macrolides, etc. Each of them, they have their own way, their action, their specificness, and accordingly we are going ahead. Again there will be many drugs as antiviral, many drugs as anti-cancer, many drugs as anti-protozoal, many drugs in anti-helminthic. So this is growing like anything. So how much you want, you plan, you think about it. If you all are agree on one thing, it's fine. If you do not agree, then I'll decide what to do. But my suggestion is there, you just look into it correctly, you think about it, whether you want to go in this way, that is now 25% or around somewhere 20 to 25%, then around 30 to 35%, and then more than that. Because anyway you have to give 2 sessional, that is very, very clear, minimum. Okay, and those who will find difficulty in the first sessional, for them the next 2 sessional can be gradually becoming more difficult, because syllabus will be too much reading, and those who start reading from the beginning, those who are making notes from the beginning, for them it can be comparatively beneficial. But those who will think that will start it later and will do something, then for them it can be very big difficulty. So you plan it accordingly. This is just advice from my side. You think in that way. Whatsoever you plan, I don't mind. Anyway, I have to make the questions, because anyway you people are not making questions. As I told you, you are not reading and not having any kind of communication over this. I'll just check how many of you are submitting this anti-tuberculosis assignment what I am giving. Okay, but I am finding comparatively very less response from your batch that way. But anyway, it's up to you. So if you can make question, fine. If you can finalize syllabus, I am giving you autonomy. I want to check how much mature your class is. Okay, and accordingly we'll plan it accordingly. Don't worry. So make it, think it, discuss it among yourself and finalize it. Okay. So take care and be safe.